Hi, everybody. This is Jeanne E Poole, the editor-in-chief of Heart Rhythm O2 Journal. This is the April 2025 podcast. This was a very full issue this month, so I'll try to be summarizing a lot of these studies fairly briefly. The first paper up is prospective evaluation of antral lesion size of the 31 millimeter size of a novel size adjusted cryo balloon. The results of the Better Fit study. This is by Dr. Nick Van Boven and colleagues. In this study, the authors purposed to evaluate the antral lesion size of cryoablation with a 31 millimeter balloon size. This is a study of the Boston Scientific Polar X Fit CB catheter. Data were collected prospectively at a single center for patients who had paroxysmal atrial fibrillation, having first-time pulmonary vein isolation. The 31 millimeter balloon was initially tried in all 20 patients, and if needed, then the 28 millimeter balloon was used. Pre- and post-ablation left atrial ultra-high definition mapping was performed to assess the antral lesion area, which is the primary outcome measure. Secondary outcome measures included procedural efficacy, including the balloon occlusion grade. The results showed that first, complete PVI was achieved in all 80 pulmonary veins amongst the 20 patients, which included 25% female. More than one-third of the posterior wall was ablated. The isolated surface area was 68.7%. Lateral and septal circumferential antral lesions were 12 and 19 centimeters squared, respectively. One patient demonstrated inadvertent overlap of the antral lesions on the roof. There was a trend toward lower complete balloon occlusion in the right superior pulmonary vein with 31 millimeter balloon size in comparison to the 28 millimeter size, 75% and 90% respectively. The authors note that this study demonstrates that the 31 millimeter Polar X Fit CB provides an acute antral lesion size that is larger than with both the 28 millimeter Polar X and the second generation 28 millimeter Arctic Front Advanced CB, but is smaller than PFA. The authors conclude that cryoablation with a 31 millimeter balloon size of a novel size adjustable CB results in a large and homogeneous antral lesion. Second, in small atria, there is the potential for leaving a small non-ablated corridor on the roof when using the 31 millimeter balloon in both superior pulmonary veins, which may be pro-arrhythmogenic. And finally, the availability of two balloon sizes in one catheter provides more flexibility. However, whether this translates into improved safety and long-term effectiveness requires further investigation. The title of the next paper is Insights from the Use of Multipolar Mapping During Ablation of Supraventricular and Ventricular Arrhythmias by Dr. Eric Brownstein and colleagues. This study is about using multipolar mapping using the Optrel Biosense Webster system to evaluate patients having SVT and VT ablations. This system provides orientation-independent near-field signal acquisition with enhanced spatial precision. The authors use this system in patients along with parallel mapping with conventional bipolar signal acquisition. Multipolar and bipolar voltage and local activation time maps were compared, and a comparison was also made between multipolar, bipolar, and unipolar electrograms in areas of interest. The authors chose 6 patient studies to report. These were chosen because differences were seen between the mapping systems. These included one each of atrial fibrillation, atrial tachycardia, accessory pathway, PVCs, and ventricular tachycardia. The authors observed 4 advantages of multipolar mapping compared with traditional bipolar mapping. 1, an improved ability to remove far-field signals while preserving the local waveform. 2, wavefront direction independence. 3, a more accurate representation of voltage. And 4, improved ability to identify the origin of focal arrhythmias. The author's key findings are, first, multipolar mapping is a novel method of electrogram acquisition and annotation distinct from unipolar and bipolar acquisitions, which provides orientation-independent near-field signal acquisition with enhanced spatial precision. Second, multipolar mapping displays an improved ability to remove far-field signals while preserving the local waveform. Third, multipolar electrograms are wavefront direction independent. Next, multipolar maps may give a more accurate representation of voltage. And finally, multipolar mapping may improve the ability to identify the origin of focal arrhythmias. The title of the next paper is Clinical Outcomes of Cases Requiring Touch-Up Applications in Pulmonary Vein Isolation with Balloon Ablation by Dr. Koshiro Kananoka and colleagues. The objective of this study was to assess the outcomes of touch-up application balloon ablation using the nationwide registry in Japan. The authors described the methods that patients with first-time PVI between January 2017 and December 2020 were included, the annual trends in the proportion of cases requiring touch-up ablation with radiofrequency ablation were determined, and the associations of ablation strategies with acute success and peri-procedural complications were analyzed using logistic regression analysis. The authors compared 3 groups of patients, those who had RF-only ablation, those with balloon-only, and then a group who required both. Of the 51,402 patients included, 28,412 had PVI with RF, and 22,990 underwent PVI using balloon ablation. Of the balloon group, 6.4% required touch-up with RF. Over time, the need for touch-up decreased from 9.5% in 2017 to 5.5% in 2020. Acute success was 99% across all ablation strategies. 2.5% of the patients in the touch-up ablation group had phrenic nerve palsy, but the composite of complications except for phrenic nerve palsy was not significantly increased. The authors conclude that touch-up applications following balloon ablation are required in some cases. Complication rates were not substantially different between those requiring touch-up versus those that did not. The title of the next paper is Atrial FDG Uptake in Atrial Fibrillation, a Systematic Review and Meta-Analysis by Dr. Ahmad Qasser and colleagues. The background of this study is that atrial inflammatory and metabolic derangements have been reported in patients with atrial fibrillation. The group of authors purposed to evaluate the association of 18F-fluorodeoxyglucose, or FDG, uptake on PET images in the left and right atria with presence and occurrence of AFib. The authors conducted a systematic review and meta-analysis using the PRISMA reporting guidelines of studies involving patients undergoing FDG PET, scans with reported atrial or ventricular uptake, and outcomes of atrial fibrillation. Data were pooled and analyzed, and FDG uptake in AF and non-AF patients was compared using odds ratios. The authors report for the results the first 6 studies, including 4 retrospective, 1 prospective, and 1 case control, were included in the meta-analysis of studies excluding patients with diagnosed sarcoid. The total number of patients included were 832 patients with a mean age of 67 years, 62% were male, and 53% had hypertension. AF patients demonstrated higher odds of FDG uptake in the left atrium and right atrium. 2 studies on patients who met diagnostic criteria for cardiac sarcoid were considered. One did not report atrial uptake, and the other did not demonstrate a statistically significant association between right or left atrial uptake in AFib patients. The authors conclude that in patients undergoing FDG PET without meeting the cardiac sarcoid diagnostic criteria, FDG uptake in the atria was strongly associated with atrial fibrillation, suggesting altered metabolism or inflammation in AF pathophysiology and risk assessment. The title of the next paper is Post-Pulmonary Vein Isolation Voltage Remapping, Guided Incremental Lesions, a Feasible Strategy to Improve Long-Term Outcomes by Dr. Juan Rodriguez-Riascos and colleagues. The authors note by way of background that pulmonary vein reconnection remains a significant problem and that the role of adjunctive strategies with repeat mapping additional lesions remains uncertain. The purpose of the study was to evaluate the impact of post-PVI high-density remapping with guided incremental lesions on long-term recurrence-free survival. The authors included 588 consecutive patients who underwent PVI between 2015 and 2023. The patients were divided into 2 groups based on whether they received post-PVI high-density remapping or they did not. Those in the remapping group with the documented areas of incomplete ablation received incremental lesions to achieve complete ablation. The primary endpoint was recurrence-free survival. The results show that the patients were followed for a mean follow-up of 25.8 months. Post-PVI remapping was performed in 243 patients, while 345 patients underwent conventional PVI. Post-PVI remapping with guided incremental lesions improved recurrence-free survival compared with conventional PVI with an adjusted hazard ratio of 0.75. The authors note that the benefit was especially notable in patients with paroxysmal AFib, hazard ratio 0.69. Complication rates and procedure times were comparable between the two groups. For patients undergoing their first RF ablation, 1-year success was higher in those who underwent PVI remapping with an adjusted odds ratio of 1.70. However, long-term outcomes were comparable between the two groups. The authors conclude that post-ablation mapping effectively identifies and addresses proarrhythmic foci, potentially reducing atrial fibrillation recurrence and improving patient outcomes. Next up is a paper with the title, Peak Frequency Can Be Effectively Used to Characterize Scar in Atrial Fibrillation, by Dr. Saeed Al-Aidaris and colleagues. The background of this study is that characterizing atrial fibrillation substrate can guide ablation strategies. The purpose of this study was to look at a novel parameter called peak frequency, PF, for its ability to characterize the substrate in atrial fibrillation. Patients undergoing persistent atrial fibrillation ablation were included in this study. Patients had omnipolar voltage and peak frequency maps during atrial fibrillation, and bipolar voltage maps in sinus rhythm at pacing intervals of 600 and 250 milliseconds. Peak frequency was evaluated at sites of fixed remodeling, or low voltage zones, functional remodeling, and non-low voltage zone areas. Peak frequency was defined as the highest frequency detected in the electrogram. Here are the key points. First, this is the first study that has extensively characterized the substrate in atrial fibrillation in the form of fixed and functional remodeling. The study showed that omnipolar voltage maps in atrial fibrillation are significantly different from sinus rhythm bipolar voltage maps at a pacing interval of 600 milliseconds. However, these differences were not significant when comparing with sinus rhythm at a pacing interval of 250 milliseconds, suggesting that AF omnipolar maps correlate better with sinus rhythm maps obtained at higher atrial rates, and thereby considering both fixed and functional remodeling. Next, a novel parameter, peak frequency, was used to characterize the substrate in atrial fibrillation. Peak frequency mapping effectively differentiated between non-low voltage zones, fixed remodeling sites, and functional remodeling sites. A peak frequency between 215 and 236 Hz was highly predictive of functional remodeling. Thereby, the combination of omnipolar voltage and peak frequency measurements in atrial fibrillation is predicted by these authors to more accurately allow the characterization of the substrate in atrial fibrillation. Finally, AF omnipolar voltage maps identified additional low voltage zones that were not seen on the sinus rhythm bipolar voltage 600 milliseconds or 250 millisecond maps, which is possible because of the underestimation of voltage due to mapping during atrial fibrillation. This is most likely the case as peak frequency at these sites was not significantly different from peak frequency obtained at non-low voltage zones in AF omnipolar voltage maps. Thereby, peak frequency can also be used to identify sites with potentially overestimated low voltage zones in atrial fibrillation. Next up is a paper titled Termination of Perioperative Atrial Fibrillation with Epicardial Cooling in the Oblique Sinus, a first-in-human feasibility study by Dr. Alejandro Trianini and colleagues. The background of this study is that postoperative atrial fibrillation is associated with prolonged hospitalization, stroke, and expense. These authors note that they have previously demonstrated the effectiveness of cooling the oblique sinus to terminate atrial fibrillation in animal models. The objective of this study was to determine whether cooling can terminate intraoperative AF in humans undergoing cardiac surgery. Patients presenting for clinically indicated cardiac surgery with a history of atrial fibrillation were enrolled. During surgery and before bypass, AFib was induced if it was not present already, and a 1x1 inch cooling device was placed in the oblique sinus that was cooled to 5 to 10 degrees centigrade at the device tissue interface. Due to this study being conducted during the COVID pandemic, the authors note that remote and real-time monitoring was used. The authors' key points include, first, that this first-in-human study showed that cooling in the oblique sinus terminates intraoperative atrial fibrillation in patients with cardiovascular disease undergoing cardiac surgery. Second, arrhythmia termination is temperature-dependent, occurring with an average temperature below 13 degrees centigrade in this observational study, and commonly occurring in under 30 seconds. There were no complications associated with cooling. Finally, this early feasibility study paves the ground for studies in awake post-cardiac surgical patients to test whether cooling painlessly terminates post-operative atrial fibrillation. The next paper's title is Intra- and Interpersonal Variation in Body Surface Potentials of Healthy Subjects by Dr. Iris van der Schaaf and colleagues. The background for this study is that body surface potential mapping can provide a detailed assessment of cardiac electrical activity and might be a potential added benefit in multiple cardiac diseases. Normal intra- and interpersonal variation in body surface potential mapping is not clearly described and could be of use in the distinction between normal variation and cardiac disease development. The purpose of this study was to describe the effects of normal respiration, changes in body position, repeated electrode placement, and heart rate differences on body surface potential mapping signals in a healthy population. 67 body surface potential mapping studies were performed in healthy individuals during 1. The resting supine position, 2. A reclined position of 45 degrees, 3. An exercise increased heart rate, and 4. A follow-up measurement in the resting supine position after 1 week to determine the effect of repeated electrode placement. In addition, R, S, and T wave amplitudes in all leads were compared between the baseline supine position and each of the other conditions. The authors note their key findings as first, normal respiration and repeated electrode placement caused the most significant changes in R, S, and T wave amplitudes, while small amplitude changes were observed during the reclined position. Second, R wave amplitude changes were largest and T wave amplitude changes were the smallest. Third, exercise generally caused an R wave decrease, a lead-dependent S wave increase or decrease, and a T wave increase. Finally, electrodes closer to the heart were prone to greater amplitude changes than electrodes further from the heart. The title of the next paper is Localizing the Origin of Focal Atrial Tachycardia by Combining Clinical Characteristics with P-Wave Morphology by Dr. Yun-Peng Ku and colleagues. The background of this is that analyzing the P-wave morphology of an electrocardiogram may determine the origin of focal atrial tachycardia, thereby providing information for mapping and ablation. The authors sought to analyze the ECG and clinical characteristics of focal atrial tachycardia patients with different origins and to improve the prior 2021 Kistler algorithm. The authors included 226 patients, all of whom had a focal atrial tachycardia treated with RF catheter ablation. The origin of the AT was determined by intracardiac electrophysiologic evaluation. The diagnostic value of the 2021 Kistler algorithm was evaluated. The ECG and clinical characteristics of frequently misidentified cases were compared with those of patients with an atrial tachycardia originating from adjacent locations. The algorithm was then modified and re-evaluated. The key findings were that 1. The diagnostic value of the 2021 Kistler algorithm was evaluated by revealing the P wave through rapid ventricular pacing in catheter laboratories. 2. The results indicated that the Kistler method, according to the authors, still has room for improvement. Third, the electrocardiogram and clinical characteristics of patients with focal atrial tachycardia originating from different locations were analyzed, and a combined localizing method was established on the basis of these results. And finally, the presence of atrial fibrillation and the incessancy of the attack can aid in distinguishing focal atrial tachycardias originating from pulmonary veins and atrial appendages from those originating from adjacent locations. The title of the next paper is Contrastive Pre-Training Improves Deep Learning Classification of Endocardial Electrograms in a Preclinical Model by Dr. Bram Hunt and colleagues. The background that the authors note is that rotors and focal ectopy or drivers are hypothesized mechanisms of persistent atrial fibrillation. Machine learning algorithms have been used to identify these drivers, but the limited size of current driver data sets constrains their performance. The author's objective is that pre-training using unsupervised learning on a substantial data set of unlabeled electrograms could enhance classifier accuracy when applied to a smaller driver data set. The authors used a SIM-CLR-based framework to pre-train a residual neural network on 100,013 unlabeled 64 electrode measurements from a canine model of atrial fibrillation. The network was then fine-tuned to identify drivers from intracardiac electrograms. Various augmentations, including cropping, Gaussian blurring, and rotation, were applied during pre-training to improve the robustness of the learned representations. The authors note the following key points. 1. Improved accuracy. Pre-training a neural network using a SIM-CLR-based framework on a large data set of unlabeled electrograms significantly improved driver detection accuracy from 62.5% to 80.8%. Second, effective augmentations. The most effective augmentations for pre-training were cropping, Gaussian blurring, and catheter rotation, which helped the network learn invariant features crucial for accurate classification. 3. Robustness to data reduction. The pre-trained network maintained higher performance even when the training data set size was reduced by up to 30%, indicating robustness and potential for application in scenarios with limited data. 4. Interpretability. Gradient-weighted class activation mapping visualizations showed that the network's attention aligned well with manually annotated driver regions, suggesting that the network learned meaningful features related to driver identification. And finally, potential for broader application. The pre-training approach is not specific to driver detection and could be applied to other electrophysiologic tasks, enhancing the generalizability and utility of this method. The title of the next paper is Comparative Durability of Pacemaker Leads in Transvenous Lead Extraction and Evaluation Through Bench Testing by Dr. Junji Morita and colleagues. The purpose of this study was to compare the tensile strength and behavior under stress of leads from differing manufacturers using different extraction techniques. Different lead types, which included the Tendril STS, the Ingevity and Ingevity Plus, the Solia S, and Capture Fix, were subjected to tensile testing using a testing machine. The leads were tested in up to 3 different configurations. The first of these was termed terminal removed. In this situation, the terminal pin side of the lead was cut, and this group was named the terminal removed group. This approach aligns with traditional transvenous lead extraction techniques in which the terminal pin side of the lead is cut. The cut end and the lead were wrapped with a 1 tie. The second group is called terminal retained. In this situation, the terminal pin side of the lead was not cut, and a liberator wire was inserted into the 1 tie wrapped around it. This is the terminal retained group. The third group is removal using a snare. In this snare group, the terminal pin side of the lead was cut, a liberator inserted, and the 1 tie wrapped around the lead. The lead was gripped 6 centimeters from the tip with a needle eye snare. The snare shaft was clamped and secured to the test machine. Lead durability was then assessed by increasing force and measuring elongation and the force required for complete disruption. The authors showed that the tensile strength of leads varied greatly based on the extraction technique and lead type. The Ingevity leads showed improved durability when secured with a snare, despite weak performance when the terminal was removed or retained. The Ingevity Plus lead exhibited enhanced durability, particularly when removed using a snare. Third, the Tendril STS lead exhibited the least durability when the terminal was removed, but had comparable durability to the Solia S and Capture Fix leads when the terminal was retained. Finally, the Solia S and Capture Fix leads had consistent, higher durability, irrespective of whether or not the terminal was removed. The author's conclusion is that this study found wide variability of lead behavior among manufacturers and with different extraction techniques. Terminal retention and snare usage enhanced lead durability, suggesting that these techniques could be considered depending upon lead type and for leads with longer implantation periods or if higher extraction forces are anticipated. The key findings are: first, terminal retention increased lead durability, whereas snare grasping further enhanced durability. Second, the lead terminal ideally should be retained during transvenous lead extraction of a tendril STS lead. And if a high traction force is anticipated because of clinical characteristics, a snare should be considered as an initial approach or adopted early during lead extraction. And then finally, a snare should be used in most transvenous lead extraction cases involving an ingevity lead. For the ingevity plus lead, the terminal should be retained and a snare considered if higher traction forces are anticipated. The title of the next study is Prevalence, Frequency of Arrhythmias and Electrocardiographic Abnormalities in Pakistan, the PAC-ECG Study, an outpatient electrocardiography-based study by Dr. Aisha Nasir and colleagues. The background that the authors note is that little is known about the prevalence of arrhythmias in Pakistan. The authors assessed the frequency of arrhythmias and ECG abnormalities amongst the Pakistani population attending the outpatient department categorized by age, gender, and geographic region. The authors purposed to evaluate variations in arrhythmia prevalence and ECG abnormalities across a large sample of the South Asian population. This is a retrospective study that analyzed 8,746 ECGs from Aga Khan University Hospital in 2022. The ECGs were digitally saved. They were initially interpreted by an ECG-trained cardiac technician. Then they were reviewed by a junior cardiologist and validated by a senior cardiologist. Finally, an electrophysiologist resolved any discrepancies to ensure accurate final results. The key findings of this study are that first, the younger population exhibits benign electrocardiographic patterns such as sinus arrhythmias and early repolarization, whereas older adults are prone to more complex conditions such as atrial fibrillation, atrial flutter, and Brady arrhythmias. Second, atrial fibrillation is more prevalent in women, with rates similar to that in other Asian populations, but lower than in Western populations. Third, atrial fibrillation is notably higher in the Khyber Pakhtunkhwa region, whereas Brady arrhythmias are more common in Gilgit-Baltistan. This first-of-its-kind study provides critical insights into age, gender, and region-specific variations, guiding personalized approaches to cardiovascular care in South Asia. We thank the authors for this insight into patients with atrial fibrillation in Pakistan. The title of the next study is Correlation between Mobile and 12-Lead ECG among Patients Loading with Intravenous Sotalol, a PEAKS sub-study, and PEAKS stands for Prospective Evaluation Analysis and Kinetics of IV Sotalol, by Dr. Benjamin Steinberg and colleagues. The authors offer as background that ECG monitoring is performed during sotalol loading primarily to assess QTC. Continuous telemetry increases resource utilization, generating interest in streamlining of QTC monitoring through mobile technologies. The purpose, therefore, was to assess feasibility and outcomes of mobile electrocardiogram monitoring during intravenous sotalol loading. This is a sub-study of the PEAKS registry. Live course 6-lead mobile ECGs were recorded during intravenous sotalol loading concomitantly with standard 12-lead ECGs. Then the authors calculated the correlation of heart rate and QTCs between them. 77 patients were included with a median age of 68 years and 20% were female. A total of 227 mobile recordings were performed within 30 minutes of a 12-lead ECG. Half, or 51% of 12-lead tracings were in atrial tachycardia and atrial fibrillation, with a 93% correlation with automated mobile diagnostics. No mobile QTC values were available for recordings in ATAF. The overall correlation between 12-lead ECG and mobile ECG was good for continuous heart rate, R greater than 0.8, but was poor for continuous QTC, R equals 0.24. Most physiologic QTC values from the mobile ECGs were within 10% of the adjudicated 12-lead values, with 53% of them within 5%. There were few false negative values for QTC greater than 500 milliseconds by mobile ECG. The author's key findings include that first, the use of mobile electrocardiograms presents a possible opportunity to reduce health care resource utilization, particularly around elective admissions for antiarrhythmic drug loading. Second, mobile ECGs can be performed during sotalol loading, but their utility is limited by the absence of QTc values in patients with atrial tachyarrhythmias. Third, there is a good correlation between automated mobile ECG analysis and 12-lead ECG for heart rate and arrhythmia diagnosis, but the overall correlation for QTc values is poor. And finally, that further research is needed to improve the accuracy of automated mobile ECG analysis, especially for QTc measurement in atrial tachycardia and atrial fibrillation, and to validate their use in routine clinical settings. The title of the next paper is Detection of Congestive Heart Failure from RR Intervals During Long-Term Electrocardiographic Recordings by Dr. Teemu Pukila and colleagues. The background of this trial is that timely detection is crucial for managing cardiovascular diseases. Recently developed computational tools to analyze RR interval sequences offer cost-effective means for early cardiac screening and monitoring with consumer-grade heart rate devices. The purpose of this study was therefore to demonstrate detection of congestive heart failure from RR intervals by discriminating heart failure from both healthy controls and patients with present atrial fibrillation. The authors also examined the detection's consistency regarding heart failure severity and AF episode frequency. The authors analyzed RR intervals extracted from several data sets of long-term ECG recordings. They used dynamical detrended fluctuation analysis, which will be referred to as DDFA, to evaluate the correlations of RR intervals and how changes in the RR intervals affect changes at another time. In addition, the authors utilized DDFA, which provides further insights into how the correlations change over time and different time scales. The resulting detrended fluctuation analysis scaling exponents are used as features in classification, distinguishing heart failure, AF, and healthy controls using the XGBoost ensemble learning technique. Now, the key findings from this paper are first, that the study achieved 90% sensitivity and 92% specificity in distinguishing congestive heart failure and atrial fibrillation from healthy controls using dynamical detrended fluctuation analysis, utilizing only the RR intervals during a 24-hour recording. Second, DDFA revealed unique RR interval characteristics for heart failure and AF patients, assisting in accurate classification of these conditions. This method provides detailed information based on heart rate and scale, capturing complex patterns in the RR interval dynamics, which conventional heart rate variability measures might miss. And finally, this approach highlights the potential of using non-invasive, cost-efficient RR interval analysis for early detection of heart failure and AF, which could be implemented in consumer-grade heart rate devices for remote monitoring. The title of the next paper is Simple Electrocardiographic Index for A4 Wave Amplitude of the BDD Leadless Pacemaker by Dr. Takafumi Oka and colleagues. As a way of background, the authors note that the A4 wave amplitude is a crucial factor determining the percentage of atrial ventricular synchrony in a mechanical sensing-based BDD leadless pacemaker. The authors hypothesized that 12-lead electrocardiographic parameters related to right atrial excitation could predict A4 amplitude. The authors aimed to investigate the relationship between A4 amplitude and 12-lead ECG parameters reflecting right atrial excitation and assess its predictive power for achieving an appropriate A4 amplitude associated with a high percentage of AV synchrony. This was a single-center retrospective observational study enrolling consecutive patients undergoing BDD leadless pacemaker implantation. The relationship between A4 amplitude and the positive peak amplitude of the P wave in lead 2, or called P2 here in this study, the positive peak amplitude of the P wave in lead V1, referred to as V1P, and the sum of P2 and V1P, referred to as V1PP2, were assessed. The author's three key findings include first, that V1PP2, the sum of the V1 positive peak amplitude and positive P wave amplitude in lead 2, was related to A4 wave amplitude after VDD leadless pacemaker implantation. Second, the A4 amplitude cutoff for percentage of AV synchrony is equal to or greater than 67.8% and was 3.2 meters per second squared. And finally, V1PP2 equal to or greater than 110 microvolts was associated with A4 amplitude equal to or greater than 3.2 meters per second squared in patients with atrial ventricular block. The title of the next paper is Premature Ventricular Contraction Detection and Estimation of Daily Burden by an Insertable Cardiac Monitor by Dr. Z. Zyko and colleagues. The authors note as way of background that premature ventricular contraction burden is a clinically important metric in the context of PVC-induced cardiomyopathy and is commonly obtained by ambulatory ECG monitoring. The purpose of this analysis is to characterize the performance of a novel PVC detection algorithm capable of identifying single PVCs and PVC sequences, couplets and triplets, for estimation of 24-hour PVC burden in an insertable cardiac monitor. Performance of the insertable cardiac monitor algorithm for detecting PVCs was validated by replaying 748 patient-triggered INCAMONT recorded ECG episodes from 184 patients through their implantable cardiac monitor device. To assess performance over longer ambulatory periods, a validated software model equivalent of the implemented ICM algorithm was evaluated against a 24-hour Holter dataset in 89 patients. The model also was used to evaluate performance as an established reference library from the Massachusetts Institute of Technology and Beth Israel Hospital databases. The key findings include, first, a novel PVC detection algorithm capable of detecting single PVCs and PVC sequences was developed for an insertable cardiac monitor. The ICM algorithm demonstrates high sensitivity for detecting ectopic beats and identifying patients with elevated PVC burden. Finally, ICM detected burden demonstrates strong correlation with the gold standard 12-lead Holter monitor, suggesting potential utility in screening for patients at risk of left ventricular dysfunction. The next paper is in our Global Voices section. The title is Permanent Pacemaker Insertion for Bradyarrhythmias in a Secondary Health Facility in Sub-Saharan Africa by Dr. Talupi Shogati and colleagues. The background of this paper is that the authors note that while permanent cardiac pacing insertion has been used clinically since 1960 around the world, and that it is a life-saving procedure for symptomatic bradyarrhythmias, that the experience of permanent pacemaker implantation in non-Western countries has not been well characterized. The purpose of this study reports the author's experience in pacemaker insertion in the newly remodeled District General Hospital Awa. The Akwa Ibom state government fully sponsored the procedures with state funds, because otherwise the patients would have had to pay out of pocket. This general hospital is fully equipped with an ultra-modern theater with CR and fluoroscopy and audio-visual facilities. There's an anteroom in the procedural suite where people can watch for virtual learning, and this is the first of its kind. A single-chamber pacemaker was implanted in all patients. There were no acute complications post-surgery. All patients were followed for at least 8 months. There were no deaths reported in this patient population, that was 8, at the 3-month follow-ups. Device interrogations were performed at the 3-month follow-up visit, and device parameters were all stable with excellent sensing thresholds. Routine follow-up for their center is a regular 2-month follow-up in the first year. The authors conclude that permanent pacemakers can be safely carried out in a well-equipped district general hospital. Most needy patients are likely to be older with complete heart block as the commonest indication. However, government or non-governmental organizations need health insurance or subsidization to make it sustainable in low-income countries to which Nigeria belongs. We thank the authors for this important paper. The next 3 papers are all case reports. I'm just going to read the title and the author. The first one's title is Iatrogenic Complete Heart Block Due to His Bundle Transection in His Lead Placement by Dr. Bradley Reinhold and colleagues. The second case report is titled Transmural Left Atrial Roofline Block Using Rescue Cryoballoon Ablation After Unsuccessful Radiofrequency Ablation by Dr. Hiroyuki Kato and colleagues. The third case report's title is Ventricular Arrhythmias and Conduction Abnormalities Following Blunt Cardiac Injury. This is followed by the last paper in this issue, which is a research letter. The title is Reaching the Unreachable in Left Bundle Branch Area Pacing by Dr. Aniti Arante and colleagues. Here, they note that left bundle branch area pacing guide catheters can be extended using a sub-selector to allow for left bundle branch area pacing lead implantation in tall patients with enlarged hearts. Okay, well, that is it for April. Thank you for listening. I will talk to you in May.